and all the amino acids are shuttled to the liver for gluconeogenesis. Same happens in the adipose tissue as well. There is increased lipolysis and free fatty acid formation in response to increase in counterregulatory hormones. These free fatty acids, they are actually mobilized to liver, and there they undergo ketogenesis. This ketogenesis will lead to ketoacidosis and start affecting the pH. So our alkali reserve, the bicarbonate, binds with this ketone bodies and tries to keep the pH in the normal range. And in this attempt, the alkali reserve drops and results in ketoacidosis. So with excess of glucose, which is being unable to enter the cell, and excess of gluconeogenesis, glycogenolysis, results in this hyperglycemia. And when the renal threshold for glucose is exceeded, there is glycosuria. Along with excess of ketone bodies, there is ketonuria. This results in osmotic diuresis, polyuria, and this polyuria causes volume depletion. Because of this volume depletion, the center is activated and there is significant polydipsia. When this goes on for a long time and the pH, the alkali reserve, the attempt of the alkali reserve to maintain a normal pH is lost, then they start manifesting with DKA, that is diabetic ketoacidosis. The clinical features, they come with vague clinical features. Parents tell that child is not active as before and has lost a significant weight. The clothes have become loose and they have nausea or vomiting. They eat more, but they have some nausea and vomiting. And they drink a lot of water, liquids, and they ask for frequent food. In spite of eating a lot, they lose weight. When they go into DKA, they start having excess of nausea, vomiting, and they have a vague abdominal pain. This ketoacidosis actually triggers the CTZ zone and causes nausea, vomiting. And the cause for abdominal pain in children with DKA is thought to be related to mesenteric ischemia. On examination, these children appear dehydrated. We can obviously see that the eyes are sunken, the skin turgor is lost, and they have a cool and chill cold peripheries. And they have this characteristic breathing pattern, Kussmaul's respiration. That is the deep and sighing respiration. This is an effort to maintain the normal pH by pushing out the excess carbon dioxide. And these children, depending on the severity of the acidosis, they are either drowsy or obtunded. And they also have a impaired tissue perfusion in the form of delayed capillary refill, cold peripheries. Their heart rate is on the higher side because of the acidosis, but they continue to maintain a BP or normal side or on the higher side because of the excessive catecholamine response. So how do we, with these vague complaints, it is easy to get deviated into a gastrointestinal cause or some other food poisoning or some other cause. So what are the pointers for early diagnosis? When there is a tachypnea, when there is a deep and sighing respiration in the absence of increased work of breathing or chest signs, which is called as effortless tachypnea, DKA should always be kept in mind. And when there are signs of prominent dehydration, we always ask the parents, when did the child pass urine output? When did the child pass urine last? So the mother will tell easily, the child is passing urine well and has passed recently, almost 2 hours back. And if that is the case, we have to ask them. There are some patients who tell that the child is waking up to pass urine at night, which is nocturia. But majority of them don't come out with a history. Their lethargy and weight loss becomes the prominent complaint for them. So nocturia, good urine output, in the presence of prominent signs of dehydration is again a pointer for early diagnosis. Vomiting and abdominal pain. On examination, we might have a diffuse mild tenderness, but there is absence of guarding and rigidity. All these suggest a systemic cause rather than a GI or a abdominal cause for the vomiting and abdominal pain. Approximately around 8 to 10% of children can have guarding with rigidity if the etiology or if the trigger for DKA decompensation is an appendicitis or a chronic pancreatitis. So what are the risk factors? Nearly almost 30 to 40% of children present with DKA at the time of first presentation. That is, they are not type 1 diabetic children. At presentation, they have DKA, and later they go on to get diagnosed with type 1 diabetes mellitus. So risk factors include children younger than 2 years of age and children with poor access to medical care and poor socioeconomic class. The later two, because there is a delay in the diagnosis, they go in for a severe DKA, and the diagnosis gets delayed and the severity of DKA becomes more. And children who have already diagnosed, who have been already diagnosed with type 1 diabetes, DKA can be precipitated more commonly when there is an intercurrent infection. Example, gastroenteritis. And when there is a severe gastroenteritis and they are unable to maintain oral hydration, then it results in a tilting of the balance and they go in for a DKA. Adolescent children and children with psychiatric illness, unstable family circumstances, all these play an important role in correct and appropriate use of insulin. So all these are they actually a hindrance, or the continuous treatment of insulin may not be possible in such conditions. So how do we diagnose? There are three cardinal features. We all know that hyperglycemia is the essential one that we check with a glucometer. Blood sugar more than 200 milligrams per dl, and acidosis. We do a venous blood gas. We don't have to really do an arterial blood gas. The venous blood gas pH is less than 7.3 or bicarb is less than 15, along with ketonemia. Ketonemia is higher ketones in blood. The problem is most of our hospitals don't do ketones in our own laboratory. They are outsourced. So what happens is we have problems with getting a blood ketone level as early as 1 or 2 hours. So the other alternative we go in for is a urine ketone. Urine ketone, it has to be in moderate or large quantities. If facilities are available for blood ketones, the major component of ketone is beta hydroxybutyrate. This has to be more than 3 millimoles per liter. Coming to the assessment, when we have an idea that this child is has features, clinical features, and the laboratory features of diabetic ketoacidosis, how do we proceed? Always, any patient who is sick or lethargic or drowsy, the assessment is by PALS A, B, C, D, E. Airway can be open. If the DKA is severe, then the airway can become obstructed because of the poor GCS. And in that case, we have to secure the airway when there is a absent airway protective reflexes. We secure the airway, we empty the stomach with a NG tube and provide a good support to the airway. This is one condition where it is a physiologically difficult airway. What happens is these children are already in a severe metabolic acidosis state, and they are trying to compensate by breathing more and washing out carbon dioxide to maintain the pH. In these children, if we attempt to paralyze them and intubate them, there is a worsening in the acidosis. That is a respiratory acidosis. Respiratory acidosis component adds to the metabolic acidosis, and there is a worsening acidosis leading to worsening cerebral edema. So children with severe acidosis, intubation should be avoided as far as possible. Coming to circulatory system assessment, they can come with shock or without shock, without hypotension, with poor peripheral pulses, or in oliguria. They can be a different range, but most commonly they continue to have a good BP and good urine output with moderate to severe DKA. Only when the medical therapy, if it is delayed, then they go in for hypotension, oliguria. And assessment, usually assessment of dehydration in these children is inaccurate, and it is just an subjective. For some people it can be 5%, for another person it can be 8%. So in a moderate DKA, we take the dehydration is approximately around 5 to 7%, and when the dehydration is more than 10%, then these children go on for hypotension, oliguria, and impalpable pulses. With the circulatory system assessment, we also attach the ECG leads to look at the rhythm for potassium abnormalities. When there is shock, we start oxygen with non-rebreathing mask. Investigations, We all do a blood sugar. We have sent a venous blood gas for pH, bicarbonate and lactate if it is done along with that, and blood ketones. This actually can be sent to the lab for beta hydroxybutyrate, or we have a point of care testing instrument similar to glucometer. Even the same about glucometer can be used to test ketones using a keto sticks. Just that the machine has to be calibrated. It is a bedside test, and these point of care test results have been comparative with the lab reports. The other things which we follow are the electrolytes. Because of the osmotic diuresis, there is plenty of electrolyte disturbances. We also check the urea and creatinine to understand the renal function. Urine for ketones. Yes, the significance of this is, in case the blood ketones, we are not able to do a blood ketone, then we can send for a urine ketones, because this has this identifies or this estimates not only beta hydroxybutyrate but more of acetoacetate. So it can be used for diagnosis but not for monitoring purposes. Complete blood counts. This tells us an idea about the PCV and hemoglobin tell us the circulatory volume and the counts, and can tell us about the presence of infection. Most of the time there is high counts, and that is attributed to the stress related to DKA and not related to sepsis. But then it still gives us an idea. When there is a fever or hypothermia, then we also think in terms of sepsis complicating the picture or sepsis triggering DKA, and then we send CRP urine routine, urine culture and blood culture. Lastly, we also send HbA1c and GAD antibody C-peptide. This is for establishing the etiology. So severity of DKA, we use either venous pH or the bicarbonate for categorizing or classifying the severity of DKA. Previously, the sensorium was also included in the diagnosis or in the classification of DKA. If it is a mild DKA, the venous pH is between 7.2 to 7.3 and the bicarb is less than 50 or between 10 to 15. Moderate DKA, the venous pH is somewhere between 7.1 to 7.2 and the bicarb is between 5 to 10. In severe DKA, the pH is less than 7.1 and the bicarb is less than 5. There is another entity called Euglycemic ketoacidosis. Usually what we see in children, the blood sugar is usually around 350 to 450. And here in this euglycemic ketoacidosis, the blood sugar ranges from 200 to 250 or from 150 to 200, not very high as in case of DKA, which we usually see. This happens when there is a starvation, when there is a history of starvation. For example, in adolescent girls with anorexia, or when there is a religious starvation, these children with glycogen storage disease or chronic liver disease, these children, they don't have that hyperglycemia which we usually see in DKA, but they have all the other features consistent with DKA, that is ketoacidosis. This is an entity which has to be kept in mind. So the treatment goals. We have identified, diagnosed DKA, we have done blood tests, and we have classified them into different severities. So how do we treat them? We are going to give them some fluids, insulin, and replace electrolytes. Fluid therapy is actually divided into two components: resuscitation fluid and deficit replacement fluid. And insulin therapy is given to bring about a control of glucose and also reverse ketoacidosis. Electrolyte replacement can be potassium, phosphorus, magnesium, sodium, depending on the condition. So coming to fluid therapy. Fluid therapy, first we'll see how to replace the how we are going to go about with the resuscitation fluid. We have to weigh the child if the child is able to walk. Most of the time children come walking to the emergency room. Weigh the child and take the present weight. If the child is really obtended, take the most recent weight and then calculate fluid. Previously, almost about 5 to 8 years ago, we were very strict on fluids with DKA. We were worried that when we give a large bolus of fluid, that children will go into cerebral edema. But of late, recent guidelines have changed that, have come up with the relaxation of the fluids. When children come with moderate or severe DKA without shock, that means without hypotension and the pulses are well felt, but they have a cool peripheral pulse and they have a prolonged CFT. In those children with moderate or severe DKA features, we can safely give a 10 ml per kg of fluid bolus of 0.9 normal saline over 1 hour. This fluid has to be subtracted from the replacement fluid, which I'll tell you how to calculate later. When patient comes with shock, that is with hypotension or oliguria or a prolonged central capillary refilling time, then it is a significant amount of volume loss, and it is very important to restore the circulatory volume, because we don't have to really worry about cerebral edema at this stage, because if this shock is not corrected, the patient is next going to collapse. So we give such patients 20 ml per kg fluids over 15 to or 30 minutes depending upon the condition, and stand near the patient and continue to reassess and watch for worsening signs. This fluid we can actually give up to 40 ml per kg and consider inotropes later beyond 40 ml per kg. So these bolus fluids, these fluids which have been used for treating shock or hypotension should not be subtracted from replacement fluids. In such a condition, always consider septic shock and administer antibiotics. So the next part of fluid therapy, replacement therapy, is the deficit replacement. In a mild DKA, the deficit is approximately 5%, less than 5%. In a moderate DKA, the dehydration deficit is between 5 to 7%. And in severe DKA, the deficit is somewhere between 7 to 10%. And here we don't replace only the deficit, but also add the maintenance fluid to it and replace this over 48 hours slowly, so that the serum osmolality falls very slowly and the patient is able to adapt to the changes. And this maintenance, here the deficit replacement is calculated using the approximate deficit calculation bias, which is subjective, and the maintenance fluid we calculate by the Holiday-Segar formula. We can use 0.9 NS, 0.45 normal saline or plasma light. There are various studies which have used different fluids at different rates, and they've almost found similar results. So we'll go and see an example of a fluid calculation. This is a 4-year-old boy who's come with moderate DKA and is weighing around 10 kg with poor peripheral perfusion. That is, his peripheries are cold and his CFT is prolonged, peripheral CFT is prolonged, but there is no hypotension. Here, this child with moderate DKA, the resuscitation fluid we can use is 10 ml per kg of 0.9 normal saline, that is 100 ml, can be given over 1 hour. After we start this, we have a rough deficit. The moderate DKA, the deficit is somewhere between 5 to 7. I take it as 6.5%, for example, and then it is 65 into 10. 10 is the weight of the child, so it comes to 650 ml. The maintenance for this child for 48 hours is around 2000 ml. So the total fluid is 650, that is the deficit. Maintenance fluid for 48 hours is 2000 minus 100 ml, which is the fluid which we gave for resuscitation. Because this child did not have hypotension, this fluid has to be reduced or subtracted from the total fluid. So the total volume comes to around 2550, and this is replaced over 47 hours, because the 1 hour of resuscitation fluid has already gone. So we replace it over 47 hours, which comes to around 54 ml per hour. This hourly fluid is usually kept below 1.5 to 2 times maintenance. This gives a rough idea if our fluid calculation is correct. And in case if the child is obese, we definitely have to use ideal body weight for height and then calculate fluids. So next comes the insulin therapy. Always have a separate IV axis for insulin, because with bolus or with a push of fluid can cause a rapid infusion of insulin and can cause hypoglycemia, rapid drop of serum osmolality, worsening cerebral edema, and so on. So insulin, it is always a separate IV axis and do not connect anything else to it. Insulin therapy, it is usually given intravenous in children with DKA. We start regular insulin, that is human actropid, and the dose which we use is 0.05 to 0.1 units per kg per hour. Of late, we have moved on to almost, in many hospitals, we have moved on to 0.05 units per kg per hour insulin rather than 0.5 units per kg per hour. And studies have also shown that there is no difference in the rate of fall of glucose or the reversal or restoration of control of ketoacidosis. But they found that with 0.05 units per kg per hour infusion, the rates of hypoglycemia are much better. So we also stick to this 0.05 units per kg per hour of insulin in our place. And this preparation is very, very important because this is going to tell us if our treatment is going to be successful or not. So we take 1.2 ml of regular insulin, that is 50 units, and add it to 49 ml of normal saline. This gives a constitution of 1 ml of fluid will have 1 unit of insulin. For example, if the child was 10 kg, the same 4-year-old child, 10 kg, if I want to start at 0.05 ml per kg, 0.05 units per kg per hour, I start at 0.5 ml per hour. This 50 ml has to be taken in a syringe, and the tubings which is going to be attached to the IV Venflon has to be connected, and this solution has to be flushed slowly. Almost approximately 20 to 25 ml has to be flushed out because the insulin has the property to stick to the plastic. So if we don't flush the syringe and tubing and connect it directly, when we start the infusion, insulin is not going to enter the system. It is just going to stick to the plastic, and thereby resulting in no improvement in sugar or no improvement in ketoacidosis. And always start insulin at least 1 hour after fluid therapy, because the primary aim is restoration of the circulatory volume. Then comes the correction of hyperglycemia and restoring ketoacidosis. In a mild DKA, this insulin infusion can be started even more at a lower dose, like 0.03 units per kg per hour, or we can directly use a sliding scale insulin. Okay, with insulin therapy, expected fall of glucose per hour is usually around 50 to 100 milligrams per dl. We have to check glucose hourly to find out how fast it falls, and also to find out if the blood glucose drops less than 250 milligrams per dl, we have to add 5% dextrose. We usually don't come down on the insulin unless ketoacidosis is totally reversed and the pH is more than 7.3 or the bicarb is more than 15. So at this stage, we have when we are monitoring sugar hourly, we might have to go up on addition of dextrose from 5% to 10% or even 12.5%, and until the acidosis is reversed. We should not use an insulin bolus at any cost, because there can be a precipitous drop in serum osmolarity, and reduce the dose of insulin only if there is a persistent hypoglycemia despite adding 12.5% of glucose. When you reduce the dose of insulin, we have to continuously monitor if the ketoacidosis is getting better or not. Coming to electrolyte replacement. Potassium is an intracellular electrolyte. This potassium undergoes a lot of shifts due to various reasons. In a child with DKA, it can be normal, it can be high, or it can be low. What happens is, we know there is hyperglycemia. This hyperglycemia is going to cause an osmotic effect. It's going to pull water, potassium, everything out of the cell. And with an acidosis setting in, it is going to increase the transcellular shift of potassium from inside to outside. And along with that, the children are going to vomit, and there's going to be significant volume depletion. This volume depletion will cause secondary hyperaldosteronism. All these will increase the excretion of potassium. So the total body potassium is going to be definitely low. But at admission, when we do the blood test, we also look for an emergency potassium value. In case it's going to be difficult, we attach a bedside ECG and look for evidence of hyperkalemia or hypokalemia. When we get the value, or when we are convinced with the bedside ECG is normal, we add a normal maintenance of 40 milliequivalents per liter of potassium chloride. Normal maintenance in otherwise well child is 20 milliequivalents per liter. But in DKA, we add a normal maintenance of 40 milliequivalents per liter, and this is added to the IV fluid before starting IV insulin. If in case the child is in shock or has oliguria, has not passed urine, or the ECG has tall tented T waves, or if there is evidence of renal failure or the potassium value is high, then we don't add the normal maintenance straight away. We wait for the urine output, we document the potassium, and then add potassium as needed. If the potassium is very low at admission, that is less than 2.5, we replace the potassium, we correct the potassium, we delay insulin until then. Why? Because addition of insulin is going to correct acidosis, and it is also going to push the potassium from the intravascular space into the cell, thereby worsening hypokalemia. So potassium estimation and addition of KCl should be appropriate, and we should anticipate the further fall in potassium also, and add potassium based on serial potassium values. Potassium can be replaced in the form of potassium chloride, potassium phosphate, and potassium acetate. When we give a higher amount of potassium chloride, this can contribute to hyperchloremic acidosis. And if we give the whole volume of potassium replacement in the form of potassium phosphate, this can precipitate hypocalcemia. Coming to phosphate, phosphate is also an intracellular electrolyte, and this acts similar to potassium. There is severe phosphate loss when there is DKA. So what happens is, this is very essential for energy production, ATP production, and there are usually no symptoms unless the values drop to less than 1 milligram per DL. When they drop to less than 1 milligram per DL, there is no energy, there is no ATP for cellular metabolism. This results in encephalopathy, hemolysis, and rhabdomyolysis. And if it is low, even values less than 2.5, we start replacing it. Half of the potassium is replaced as potassium chloride, and half of it is replaced as potassium phosphate. Potassium phosphate 1 ml has 4.4 milliequivalents per liter of potassium and 3 millimoles per liter of phosphate. This is twice as in potassium chloride. There is a risk of hypocalcemia if the whole potassium is replaced in the form of potassium phosphate. The last electrolyte, soda bicarbonate. Because there is severe acidosis in DKA, it does not mean that we have to give soda bicarb. The acidosis because of ketone bodies and excessive ketone production. So the way to correct acidosis in DKA, we all have understood, restoring the circulatory volume, and also the hyperglycemia with insulin. When we give insulin, glucose starts entering the cell and is available for energy and metabolism. So the other forms of energy producing substrates, they come down, and this ketone bodies get excreted better when the circulatory volume improves through the kidney. But what happens when we give soda bicarbonate for a severe acidosis patient? They say it causes CNS, paradoxical CNS acidosis. What happens is, instead of the bicarbonate entering the cell, there is much of carbon dioxide entering the cell and causes intracellular acidosis, worsening cerebral edema. So are there any situations where we can use soda bicarb? There are two situations in a severe DKA. When there is a severe acidosis, the cardiac dysfunction sets in and our catecholamines fail to act. In such a situation, and in a life-threatening hypokalemia, we use soda bicarb. Even then, when we use soda bicarbonate, we give a 1 milliequivalent per kg very slowly over 1 hour. We don't give a bolus soda bicarb. And with the initiation of treatment and with fluids, insulin, and electrolytes being replaced, what are the things which has to be monitored, and what are the calculations which we have to do during monitoring? Anion gap. This is one which has to be really done every second hourly when we check the electrolytes. Usually in DKA there is a high anion gap acidosis, usually between 20 to 30 millimoles. But when there is a even higher anion gap, more than 35, we have to think in terms of lactic acidosis because of sepsis or renal failure. The aim of DKA management is to normalize the anion gap. Second one, we calculate the corrected sodium. Why corrected sodium? In DKA, there is a dilutional hyponatremia or a pseudohyponatremia. Because of hyperglycemia, it exerts an osmotic effect and draws in a lot of water. the intravascular system has a lot of water and there is a dilutional hyponatremia. And in DKA, because there is excess of lipids, it can cause a pseudohyponatremia. But in our labs, because of the method with which we test the sodium, we don't have a problem with pseudohyponatremia. So what does corrected sodium mean? It is going to tell us the expected sodium in the absence of hyperglycemia. This is very important because for monitoring the progress of the response to treatment, we need to know the corrected sodium. So this is calculated using the measured sodium is added to 1.6 times the glucose minus 100 by 100. If the blood sugar is 450, we calculate like this: 450 minus 100 is 350. 350 divided by 100 is 3.5. 3.5 times 1.6 is added to the measured sodium. This corrected sodium is always higher than the measured sodium. What we aim to correct, how we aim to correct sodium when we are treating DKA is there should be a slow rise of the measured laboratory sodium and there should be a slow decrease in the corrected sodium. If these two happens, then we are in the right track. The next very important thing which we have to calculate is the effective osmolality. Effective osmolality is produced by substances which can exert an osmotic effect across the cellular membrane and it does not cross the cellular membrane. This is usually done by sodium and glucose. So the effective osmolality is calculated by twice the sodium, by adding twice the sodium and glucose by 18. In DKA, the osmolality usually, the measured calculated osmolality is usually between 300 to 330 or 320. Only in hyperosmolar, hyperosmotic state, the osmolality is more than 330 or up to 350 also. So we have to aim at normalizing osmolality very slowly, and this gives an adequate response or the right way of continuing treatment. Coming to monitoring, there are few things which has to be done continuously, few things which has to be checked hourly, and so on. So there has to be an ECG which has to be attached continuously to monitor for changes related to potassium, and BP, heart rate, saturation, respiratory rate, everything has to be monitored continuously. Hourly, blood sugar, GCS, pupils, intake output chart, and second hourly, we usually send electrolytes, calculate the anion gap, effective osmolality, and the corrected sodium to know if we are in the right track. We do fourth hourly, we do a venous blood gas and serum or a point of care ketone assessment if possible. This is an example of the chart which we use in our ICU. Every hour we keep monitoring sugar and the insulin dose, IV fluid intake and the output, and second hourly electrolytes, and fourth hourly the pH and ketone bodies. So when do we say that the DKA has resolved? When the blood sugar is persistently below 200 and the bicarbonate is more than 15 or venous pH is more than 7.3. We also have to aim at an anion gap of less than 14, that is a normalization of anion gap, and that is the time when we can be very sure of the resolution of DKA and we can go ahead with switching over to subcutaneous insulin. Serum beta hydroxybutyrate should be less than 1 millimole per liter. When these things happen, then the DKA has resolved. So with monitoring and treatment continuously happening, what are the things we have to look out for, or what are the complications which we can expect? Cerebral edema, hypokalemia, hypochloremic acidosis, and hypoglycemia. DKA, the mortality in our developing countries somewhere around 3 to 13%. So much of it is because of cerebral edema. Almost 60 to 90% of death in DKA is because of cerebral edema. So when can the cerebral edema set in? The children can actually present to the hospital with features of cerebral edema, or in the initial first few hours, almost 8 to 10 hours of treatment with cerebral edema. The pathogenesis seems to be evolving over a period of time. We initially thought that rapid fluid bolus or soda bicarbonate therapy as a treatment for the treatment of severe acidosis were all causes of cerebral edema. But as of now, new hypotheses are coming up, and it tells us that it is not related. Cerebral edema is not related to treatment alone. It can happen even before the treatment is started. What happens is when there is hyperglycemia and osmotic diuresis with renal perfusion going down, there can be a lot of toxins accumulating, and these toxins can cause a cytotoxic edema. This can incite an inflammatory response. When the treatment starts, there is a reperfusion injury and there is resulting vasogenic edema with a breach in the blood-brain barrier. And the risk factors for them are younger age, newer onset diabetes mellitus, and there is a delay in diagnosis. All carries an increased risk factor for diagnosis for cerebral edema. The other things which we all know is a severe hypocapnia, that is a PCO2 levels which are far less when compared to the acidosis or when compared to the bicarb status. Setting of renal failure, again the risk is more. Severe acidosis, bicarbonate therapy for acidosis, a rapid fall in osmolality either by use of an insulin in the first hour of treatment or larger volumes, all these are risk factors for cerebral edema. The ISPAD guidelines, they have given a beautiful criteria on how to diagnose cerebral edema. There are 4 features in diagnostic criteria, 3 in major and 5 in minor. When one diagnostic criteria with 2 major or 1 major with 2 minor is present, the sensitivity of having a cerebral edema is almost 92%. The diagnostic criteria says that when there is an abnormal motor or verbal response to pain, that is, they have a decorticate or decerebral posturing, cranial nerve palsy or abnormal respiratory pattern, then they are having, then it is a diagnostic criteria for cerebral edema. Major criteria when there is a fluctuating level of consciousness, sustained bradycardia which is not explained by the improved response to ketoacidosis or an improvement in the circulatory volume, and when there is an age inappropriate incontinence. These are major criteria, and in minor criteria we have small things like vomiting, headache, lethargy, diastolic BP more than 90 and age less than 5 years. These signs, when they are present prior to our initiation of treatment, should not be considered as cerebral edema. Why? Because children with severe DKA, they already have had multiple episodes of vomiting, they are very lethargic, and they can have an abnormal response to pain. We pinch them, they hardly moan. So we cannot make a diagnosis of cerebral edema at admission. And with treatment, during the treatment, when they develop a new neurological sign like this, headache or vomiting, worsening headache, or increasing episodes of vomiting, decorticate or decerebrate posturing, then our treatment has tilted them to go into cerebral edema. When there is, during the process of treatment, when there is a high urine output and there is a high serum sodium, then it is a sign of central DI. It means that there is a herniation and there is a blood supply which is being cut off to the pituitary stalk. So how do we manage them? Once we establish the diagnosis of cerebral edema, reduce the fluid rate. If in case in a 4-year-old child we were giving a fluid rate of 54 ml per hour, this fluid has to be either halved or made 1/3, aiming at normal perfusion and normal BP. It can be made either 25 ml per hour or 35 ml per hour. Start hyperosmolar therapy immediately. This hyperosmolar therapy, it is always safe to be available at bedside, because with the diagnosis, they don't give much time. They progress on to having a cerebral herniation very soon. So it is always important to have this hyperosmolar therapy, mannitol or hypertonic saline, at the bedside. Mannitol is given 0.5 to 1 milligram per kg as a bolus over 15 minutes, or 3% saline of about 2.5 to 5 ml as a bolus over 15 minutes. There are multiple studies which have compared mannitol and 3% saline. For non-DKA related cerebral edema patients, we all have moved, many of us have moved from mannitol to 3% saline. Similarly, when they compared the response to treatment in mannitol versus 3% saline, they found that children who were treated with 3% saline had a higher mortality rate. But this was not taken as a statistically significant event because the demographics were totally different. We need further studies to find out which is better, or if both are equal or same. We also start them on ICP measures. We keep the head end elevated, we maintain a normal temperature, maintain normal oxygen, carbon dioxide, and cerebral BP, mean BP for cerebral perfusion pressure. We intubate these children only if the GCS is very poor or if there is a respiratory failure. After stabilizing them, we take them for an imaging to find out if there is any hemorrhage or thrombosis based on focal neurological signs. The second complication which we face during the treatment of DKA acidosis, DKA is a persisting acidosis. If the bicarbonate levels is less than 10 for more than 10 hours of treatment, after 10 hours of treatment, then we call them as persisting acidosis. What's the first thing we have to do when we have a persisting acidosis is to calculate the anion gap. Anion gap, we all know that bicarb plus chloride, we subtract it from sodium and we get the anion gap. If the anion gap is high, it is always mostly related to the insulin therapy. The IV line site, the IV Venflon might not be in place, it might have extravasated, or the insulin might not be prepared adequately, or the tubing might have not been flushed properly, or the rate which has been set might not be proper. So we have to go back to the line, start from the line and come up to the syringe with insulin to check everything is okay. If you still have a doubt and you're very not sure if the tubings were flushed or not, you can start a new insulin infusion. And occasionally it can be because of lactic acidosis because of sepsis and renal failure. When there is a normal anion gap, this acidosis is because of hyperchloremia. And this we can identify using a simple formula. Sodium minus chloride, if the difference is less than 30, then there is hyperchloremia. In such situation, we switch over to plasma light from 0.9 NS, and then we can also replace the potassium as potassium acetate or potassium phosphate instead of potassium chloride. Usually this hyperchloremic acidosis settles within 4 to 8 hours of change of fluid. Now, the other complications which we can face is hypokalemia, hypoglycemia, which we have already discussed on how to manage them. Coming to the risk factors of poor outcome in DKA. Most of the children with DKA, they get better, they really improve, they get back to normal within 24 to 36 hours of admission. But there are few risk factors. Having a cerebral edema at admission or during treatment, presentation with renal failure or sepsis, they have very poor outcome in DKA. So having a cerebral edema or renal failure at admission, both of them indicate a significant delay in diagnosis and appropriate therapy. There have been number of studies which show contribute these risk factors for poor outcome. Now, there is resolution of DKA. The patient is stable enough and is willing to take orally, and this is the time we have to switch to subcutaneous insulin therapy. This switch is usually done during a meal time because it is easy to plan further events. And when we switch to subcutaneous insulin, we actually go on for 2 types of insulin. That is the basal bolus or long-acting glargine and a short-acting or fast-acting insulin. This basal bolus can be started even during an IV insulin therapy. Now, the recent guidelines say that the earlier we start the basal bolus long-acting insulin, the better is the hyperglycemia or the glucose control. So this basal bolus is usually calculated as 0.3 to 0.4 units per kg and is given as a single daily dose, usually at night around 8 or 9 p.m. And this, the short-acting or the fast-acting insulin, this is actually chosen depending on the local practices, whichever the patient is comfortable with and the treating doctor is prefers to. And this is actually Lispro or Aspart. This short-acting subcutaneous insulin has to be given 30 to 60 minutes before we stop the IV insulin. We calculate almost, if the child is 10 kg, we calculate 1 unit per kg, that is 10 units, and divide it into 3 meals. We give 3, 3, 3 in the 3 for different meals. And if we are using a short-acting insulin, we actually have to give this subcutaneous insulin half an hour before the meal. In case we use a rapid-acting insulin, we can give the insulin and give a meal within 10 minutes. We have to keep checking sugars very meticulously to titrate the insulin doses. We check them pre-breakfast, pre-lunch, pre-dinner, and at 2 a.m. to titrate insulin. After switching over to insulin, regular insulin, usually we take a detailed endocrinology consult, we take a dietitian's opinion, and do a detailed patient but parent counseling. The treatment of DKA is not successful until we do this parent or patient education. If this is not done, they're going to go in for DKA again and again, and they're going to have serious poor outcomes. So we have to teach them on what is the need for glucose monitoring, how to do a carbohydrate count, and type or dose the insulin. We have to tell them the different types of insulin available and why they are being given. We have to ensure record maintaining and also tell them about sick day protocol and management of hypoglycemia, and ask them to come for regular follow-up. Just one image on hyperglycemic hyperosmolar state. Here the difference is the hypoglycemia is more in hyperglycemic hyperosmolar state. That is, the blood sugar is more than 600 milligrams. Here it is usually in the range of 350 to 450. Ketoacidosis, ketonemia is absent, and ketonuria can be mild or absent. Here there is severe ketosis or ketonemia. Dehydration is prominent in HHS. It is reasonably less in DKA. The osmolality is usually above 330 milliosmoles per kg, and in DKA the osmolality is somewhere between 300 to 330, usually between 300 to 320. And the electrolyte deficit is also prominent in HHS compared to DKA. There is a significant drop in sensorium or profound lethargy or obtundation in HHS when compared to DKA. Here the treatment is totally different. Fluids are given at a higher rate. After the restoration of, after replacing the resuscitation fluid, we actually start them on 0.45% NS, 0.45% NS, and we give replacement fluids at a little higher rate. And insulin is usually started at very low rates. We usually start at 0.02 units to 0.05 units per kg per hour in HHS when compared to DKA. Now a last slide, a last point on DKA in this COVID times. Once you put DKA and COVID-19 in the internet, Google shows so many articles from different parts of the world. There are few articles which shows these reports. This is from the Northwest London. They have found that in the last 6 months, they have seen twice the number of patients coming with DKA compared to the previous years. This was done in 2 hospitals in the Northwest London. 70% of them were found to present with DKA, and of that there were almost 22 children in the last few months where they studied, and of that, of the 22, 2 people had a PCR positive and the remaining 5 had SARS antibody positive. It means that 1/3 of population either had a PCR or an COVID antibody positive. There are similar reports from China and Italy, and this is from Germany. Here again the incidence was double, and here 45% of children had presented with DKA. 25% of them had severe DKA. Here they attributed various reasons for children presenting with severe DKA, because there was a fear of approaching to healthcare facilities, non-availability of healthcare providers, and few psychosocial factors also played an important role in the delay of diagnosis. This is a paper from Mumbai. Here they have treated a 15-year-old previously well child with DKA who presented with DKA. This child actually had all features of DKA at presentation, and they started her on resuscitation fluids. During the treatment, first initial 6 hours, she progressed to have an abnormal neurological worsening associated with acidosis. Keeping cerebral edema in mind, they managed symptomatically, and they also did a chest X-ray. They found little bilateral infiltrates, so they went ahead to do a SARS-CoV-2 PCR, and here the PCR was positive. She was also started on hydroxychloroquine. This happened sometime in May 2020. She was started on hydroxychloroquine. She, when this cerebral edema set in, she also had some hypotensive shock and also renal failure, which with symptomatic management, gradually she improved over 2 to 3 days. this acidosis took, hyperchloremic acidosis and the renal failure acidosis took almost 4 days to improve. Then this child gradually improved and became normal and was discharged fit. Here they say that because we all know that ACE2 receptors are expressed on beta cells, and this SARS-CoV-2 COVID-2 virus has a predilection for this receptor. And these when the virus binds to these receptors, they destroy the beta cells, leading to insulin deficiency, and they tilt the balance. In these children, the HbA1c is usually high, which means that there has been a setting of type 1 diabetes already in such children, which is not being diagnosed, and this COVID or this viral infection tilted the balance, and they presented with a DKA, severe DKA. There has been similar experience with SARS in 2002, 2003, and with H1N1 in 2010. So a few more. Diabetes was definitely considered an independent risk factor in SARS in 2002 and H1N1 in 2010. And here in these patients, when they were followed up, the hypoglycemia were seen to persist for almost 3 years, after which they settled. This indicated a transient damage to the beta cells by the SARS virus. So our unit, we've almost had 5 children with DKA presenting to us in the last 45 days, which is a significant number, and of which only one girl who was 9-year-old was positive with SARS, positive with COVID-19 virus, and all the children turned negative. We did not do an antibody or the serology SARS antibody on these children. We just did a PCR. When we went back to the literature, because we were seeing a lot of patients with DKA in these last few days, we thought we will go into the literature and found out that there have been similar reports across the world. And in all our patients, the HbA1c was very high, which means that the glucose control has been poor or has gone uncontrolled in the last few months. Maybe it was just the COVID virus which tilted the balance, or it can be antibody response to COVID, which caused autoimmune response and caused a damage to the pancreas, leading to insulin deficiency. We really don't know, and we have to have a lot of studies and keep doing research on these associations with this virus and DKA or type 1 diabetes mellitus in children. We still have to follow up children to find out if this is going to be a permanent damage or if it is just a transient damage like what we saw in children with SARS. Thank you, and thank you for patient listening. It has been a... If there are any questions, I don't see any questions here. You can unmute yourself, and if there are questions, I will definitely help you answering. I think if there are no more questions, we would end this meeting, and I wish it was useful to some extent.